Okay, good evening, everyone. Welcome to our presentation today. Ouch, my shoulder hurts. My name is Sue Breithaupt. I'm a health educator in the Valley Hospital Department of Community Health. Just a couple of announcements before we start our presentation. If at any time you have questions or any comments you want to make, please feel free to submit them through the Q&A or the chat box. It's the bottom of your screen. You just click on there and you can type in a question at any point during the lecture. We should have a few moments at the end of the presentation to answer some general questions. Just keep the questions general. For any specific questions regarding your health, we do recommend that you follow up with your physician. At the completion of this event, you will be receiving another email from Valley's Community Health Department, which will include a link taking you to an anonymous survey about the event. Please take a moment to complete the survey as your feedback is very important to us. And now I'm going to introduce our speaker for this evening. Dr. Umer Dasti is a board-certified orthopedic surgeon specializing in shoulder surgery, and he is with Ridgewood Orthopedic Group in Ridgewood. Thank you for being with us this evening, Dr. Dasti.
Hi, everyone. Thank you. Thank you, Sue. I think I will share my screen. I have a PowerPoint because a picture is worth 1,000 words.
There you go.
Yeah. Everyone see that?
Yes, I see it.
Okay. Yeah, so ouch, my shoulder hurts. I've done this talk before. This is a better name. I've had some funny names given to me. I don't get the name to like it. I like this one. Like Susan said, this is just a little bit about me. I'm a board certified orthopedic surgeon. I did some additional training in sports medicine and specifically shoulder surgery. At this point in my practice, I do mainly focus on shoulder treatment of shoulder injuries. We don't just do surgery, of course. We do a lot of non-surgical treatment in the office, physical therapy, injections, things like that. I joined Ridgewood Orthopedic Group and Valley Hospital 10 years ago. This past summer was my 10-year anniversary, and I'm very happy there. So yeah, ouch, my shoulder hurts. I thought we'll just kind of talk briefly about the shoulder a little bit, and then I picked out kind of the top 3 most common causes of shoulder pain. And we'll go through those in a kind of broad sense and talk about what they are and some treatment options, and then we'll have some time for questions. I have some extra slides at the end, some hidden slides about some other topics in case there's questions. We can talk about some other things if they interest people. So introduction to the shoulder. One thing to start off with is kind of a lot of people come in and say, well, where is the shoulder bone? So there is no bone called the shoulder, right? The shoulder is an area of the body. So the shoulder is that kind of area where the upper arm, the humerus bone, meets the shoulder blade and meets the collarbone. And that whole area we call the shoulder. So it's not an actual bone, it's a joint. There's the shoulder joint. And medically, we call it the glenohumeral joint. The glenoid is the medical term for that, the socket on the end of the shoulder blade. And the humerus is the upper arm bone. So we call that joint the glenohumeral joint because there are a couple of other little joints in that area. There's the collarbone joint, which we call the acromioclavicular joint. And then there's the scapulothoracic joint where the shoulder blade meets the chest or the thorax is technically another joint. So there's kind of 3 joints there. The main joint, that glenohumeral, that big ball and socket joint, people call that the shoulder joint, colloquially speaking. This is a little bit of overview of the bones. So our main bones there are the humerus, the scapula, also known as the shoulder blade, and the clavicle or the collarbone. If we start diving a little deeper, we would see kind of the first layer of muscles there, and the big shoulder muscle is the deltoid, big cuff. It looks like a shoulder pad, like a football pad over the top of the shoulder. That's called the deltoid. It's a big triangle-shaped muscle. Then, of course, you have the pectoralis, the chest muscle. Then you have the the arm muscles, the biceps. If we were to take off then that outer layer, that the deltoid and the pec, we see a little bit deeper here, the picture on the right, and you start to see some of the rotator cuff muscles, which we're going to look at a little bit closer. So a lot of people have heard of the rotator cuff. It is the rotator cuff, not the rotator cup. Some people say rotator cup. Some people, it's the rotator cuff, and it's a cuff because it's kind of a group of muscles, and it sits and it surrounds the top of the humerus, the top of the upper arm bone. And so the rotator cuff is actually four muscles and therefore four tendons. Muscles become tendons where they attach to the bone. So those four muscles are the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. So that group of four muscles we call the rotator cuff. Subscapularis in the front, the supraspinatus at the top. You see that one here. This is looking at it from the back. This is looking at it from the front. Then the infraspinatus and the teres minor. The most commonly injured part of the rotator cuff is that one at the top, the supraspinatus tendon. So when people say I have a rotator cuff tear, most commonly what's happened is that supraspinatus tendon, the one at the top, has torn. And we'll talk about that a little bit. Another important muscle up there, another important structure is the biceps. And the biceps is actually two muscle heads, therefore the bi, from the Latin bi, and it's got two attachments up at the top, a short head and a long head. And that long head of the biceps, this is a little bit better picture. This is the short head. The short head comes more inside over the chest. The long head comes up. It's a very narrow, thin tendon, and it makes this 90-degree turn at the top of the shoulder bone. It runs right alongside those rotator cuff tendons, and it's often implicated in shoulder pain, and it often comes hand in hand with rotator cuff tears. People can develop problems with the biceps tendon. And then if we go one layer deeper, then we see the actual joint. Now we've got rid of all the muscles, all the tendons. We see the socket here. Again, that's called the glenoid, and it's got a very smooth cartilage. Like all of our joints, wherever two bones meet, they have a very smooth cartilage on them. And so likewise the shoulder. So on the glenoid, on the socket side, there's this very smooth cartilage. And around the rim of it is a thicker rubbery type of cartilage. We call that the labrum. And then there's a smooth cartilage on the top of the humerus and this hemisphere, kind of the ball that makes up the ball and socket joint of the shoulder. So that's a little overview of kind of the anatomy. That's a quick anatomy lesson. And so that will help us kind of, better understand some of these next few topics that we're going to talk about. We're going to get into some of the most common causes of shoulder pain. Like I said, I've picked out, if anyone's joining us late, I've kind of picked out three of the most common issues I see in the office, and three of the most common things we end up doing surgery for, and we'll kind of go through them and talk a little bit about what they are and a little bit about their treatment. So the first thing here we've pulled off is bursitis, tendinitis. It's kind of a spectrum. This kind of stuff falls into a spectrum. Another term you could use for this is shoulder impingement. And essentially what it is inflammation of those rotator cuff tendons at the top of the shoulder, or inflammation of the bursa, which sits around those tendons. I didn't talk about that in my anatomy lesson, but that the bursa is kind of represented here by this blue sac. Although it's not exactly a clear balloon-shaped sac like this is depicting, but this gives you an idea. It's a thin layer of tissue that surrounds the tendon, that cushions the tendon, protects the tendon, and it sits between the underside of the shoulder blade, and it sits over the top of the rotator cuff tendons. So when you have shoulder impingement, when you have a problem in that area, inflammation of that area, you can have inflammation of that bursa. You could have inflammation of the tendon, of any of the rotator cuff tendons. You could have inflammation of that biceps tendon. They all, in the end, kind of boil down to the same thing. A lot of pain over the top of the shoulder, pain when you bring the shoulder up and pinch that area. And so we also call that whole kind of call them collectively impingement syndrome. And so there's no tear in these cases. This is just inflammation. There's no actual structural damage. This, we see this in the office, pain there, pain when you lift the arm, pain coming up, oftentimes pain at night. A lot of these shoulder issues give you pain at night. So we can sometimes diagnose it based on exam. Ultimately, if we really need to know, we can get an MRI. An MRI will show it. An MRI will show that you don't have a rotator cuff tear. You just have some inflammation of that rotator cuff tendon. Treatment for this is non-surgical, non-surgical, non-surgical. Surgery should be a absolute last resort for these types of cases, tendonitis, bursitis. The vast majority of the time, we can get this to clear up, go away, heal, resolve, get rid of the inflammation with some combination of sometimes just rest, modifying activity, resting, not going to the gym, modifying in the gym, modifying your sport, modifying your lifestyle a little bit. We do a lot of physical therapy for this. So a lot of what triggers it in the first place is posture. Like I'm sitting here on my computer and I'm, using the mouse. And so where our shoulders are hunched and we're all on the computer these days. All of our meetings are on Zoom like this. These used to be in person, but now they're on the computer. So a lot of it is posture related. So therapy can work on your posture, bringing your shoulder blades back, opening up that space. We know when your posture is good, when your shoulder blades are back, that space, like that space where the rotator cuff tendons sit underneath the shoulder blade, that space opens up, that space becomes wider, and you're less likely to pinch the tendon, irritate the tendon, and you give that tendon a chance to heal. We also do, oral anti-inflammatories, things like Advil, Aleve, if someone can take them, or prescription versions of those things. The next kind of step up the ladder would be cortisone injections. So many times we do end up doing cortisone injections. It shouldn't necessarily be the first step, except in kind of really severe cases. Some people come in with a lot of pain from this. And you can do a cortisone right off the bat. Otherwise, I try to convince people to try some time, therapy, anti-inflammatories, rest. But we do cortisone injections for these in the office. Cortisone is just a very powerful kind of concentrated anti-inflammatory injected into that area. If all else fails, as the last resort, you can have surgery. We go and clean out that inflamed bursa sac, for example, or clean out the inflamed portion of the tendon. Sometimes what's precipitating this is a bone spur on the underside. Some people are born with it or develop a bone spur on the underside of their shoulder blade. And so when they bring the arm up there, they pinch that tendon. And so sometimes as part of that surgery, if we do surgery, we'll go in and shave down that bone spur to kind of take care of the root cause, so that the inflammation doesn't come back, so tendonitis doesn't come back. All right, the next topic I think is rotator cuff tears. So this is it's related in some ways. Sometimes tendonitis, bursitis, an inflamed tendon goes on to become a partially torn tendon, and then sometimes a fully torn tendon. So again, this is still on that same spectrum of rotator cuff tendon problems, it's obviously a little bit worse because now you're talking about an actual structural failure of those tendons. Usually these tendons fail where they attach to the bone. So there's certain places in the body, certain tendons that if you tear them, normally you tear them in the middle of the tendon. Like the Achilles tendon is a well-known one. If you tear your Achilles, usually you tear the Achilles in the middle. And so if you have surgery for that, you're taking the tendon ends and repairing the tendon end back to the tendon itself. The rotator cuff is a little different. If it tears, usually what actually is happening is the tendon is tearing off the top of the arm bone where it attaches to the arm bone. And it can be usually one of the four tendons, sometimes two, three, very, very rarely four. Obviously, the more tendons, the worse it is. Broadly speaking, you can break down rotator cuff tears in a couple ways. You could describe a tear as being partial or full. So a full tear would mean the whole thing is completely detached, kind of like this picture is showing here. A partial tear means there's some fraying, like some ulceration. If you imagine or maybe a rope, I think I have a picture later on, a rope that was rubbing on a sharp edge, and um, it hadn't completely kind of given out. Some of the fibers of the rope are still attached. That would be the equivalent of a partial tear. So we'll sometimes describe a partial tear as 20% torn, 50% torn, 75% torn, and then fully torn. The other way you could break down rotator cuff tears is to kind of broadly speaking is traumatic or degenerative. So the traumatic tear would be a tendon that was completely healthy. It was a perfectly good tendon, no issues, and someone just had a really bad injury, a bad fall, a car accident, a sports injury, and that tendon just ruptured, just tore, suddenly went from nothing to being torn. More commonly, actually, what we see are what we call degenerative tears. So these are wear and tear type of rotator cuff tears. This is that kind of tendon tear that's starting off as maybe an inflamed tendon, then it's a partial tear, 25%, then it's 50%. It's slowly kind of fraying. I think I have, yeah, this is my little rope example I was given. So you can imagine a rope like that that's slowly fraying, and then it tears. That's kind of like a degenerative tear. This is kind of showing an example. So this is kind of a partial tear. You see some of the tendon is still attached to the bone here. The tendon is detached in this region. It's still attached here. Whereas this one, the tendon has totally detached and now it's pulled back. It's pulled back here, a couple centimeters. Let me back up a little bit. So rotator cuff tears, how do they kind of present? What do those people say? Usually they come into the office, they have, again, a lot of pain over the top of the arm. Very commonly pain, anything, even the tendonitis bursitis. For whatever reason, the way we're wired, our pain fibers very commonly pain up here, and up people come in, the pain is here. The problem is here, the pain is here. Pain moving the arm, pain lifting the arm. And if it's really a big tear, bad tear, people say, I just can't lift the arm. It hurts too much and I just can't lift it. Diagnosis, again, similar to the bursitis tendonitis. Sometimes we can tell based on examining you in the office. Many times we do end up getting an MRI to confirm that. Remember, x-rays show bones, but this is a tendon problem. So we need the MRI usually to see the cartilage and the tendon. Treatment depends on where you are in that spectrum: partial, full, small, medium, large, 1 tendon, 2 tendon, 3 tendon. It can be rest, activity modification, a lot like the other stuff, physical therapy. When it comes to the tears, especially a full tear, now I have a lower threshold to start talking about surgery. Tendonitis, bursitis, throw everything at it, give it 6 months, give it a year, no problem. Let's try to get it to clear up. A full tear is a little bit of a different story. You'd have a lower threshold to start talking about surgery. We looked at this, the partial tears. Yeah, definitely the partial tears. I have that thing in there, partial tears, avoid surgery, exclamation mark. Yeah, definitely the partial tears kind of fall into that same category as the bursitis tendonitis. Try everything. Try 3 months, 6 months of physical therapy. Give it time. Many of them can heal, or at least the pain can go away and you can avoid surgery. Full tear is the opposite. If you're on the younger side, you're healthy, you're active, we're usually going to be talking about surgery because they usually don't heal. Once they're fully torn, like this picture shows, and the tendon has pulled back a little bit, short of surgery, there's never going to be a way to bring it back. Some people can live with a full tear, but they're never actually going to heal. But depending on age and activity level, they can be treated non-operatively, but that you have to explain that means that tendon's probably never going to heal. Some people tolerate it okay, and a lot of it depends on lifestyle and activity level. This is an MRI example. MRIs are hard to kind of read, but they're slices. We get like a couple of hundred slices through the shoulder, and we kind of create a 3D picture in our mind. But this is showing a healthy normal tendon attaching to the top of the arm bone. This is the arm bone. This is an example. Again, this is the arm bone, the humerus, top of the humerus. That white area is the gap that's now been filled with just kind of joint fluid because that tendon has torn and it's pulled back here. So this is the edge of the tendon that should be here. The white is the gap. So I know a lot of people are here probably to hear about kind of the surgery side of things. I am a surgeon. Like I said, we try to avoid it, but oftentimes it is necessary. Previously, probably, definitely, like I said, I've been in practice. I've finished my training 10 years ago, and at least in that time, arthroscopic surgery is the gold standard. I'm certainly doing 100% arthroscopic surgery. I would say probably that probably became the gold standard 15 years ago. Um, Previously, they were done open, meaning it was an incision, medium-sized incision over the top of the shoulder. I had to separate that deltoid muscle, detach the deltoid muscle to get down to the rotator cuff tendons and fix it all up. Now we do it arthroscopically. It's usually four little poke hole incisions and go in with the camera and fix it. Um, this is an example of what we see through the camera. This is the torn tendon. This is the top of the shoulder bone. We put in these are little diagrams. Um, we repair that tendon. We reattach that tendon to the bone. I think this is a video. I hope this plays for everyone. I'll speed through this a little bit. What time is it? 7:20. Yeah, this is the top of the arm bone. This is the rotator, one of the rotator cuff muscles. The red is the muscle, the white is the tendon. This kind of crescent is the tear. This gap here should not be there. This is torn. I think we will see. Yeah, they're kind of showing you there it torn and it pulled back. So they're showing you here, this is pulled back a couple centimeters, maybe half an inch of retraction. We clean up the stump of tendon. We put in, I'm going to fast forward here a little bit. We put in something called suture anchors. These are made out of plastic. They have very thick sutures on them, almost like shoelace size. And we pass these through the tendon, do it again. And now the tendon, as you can see, that gap is gone. That gap is gone. Now the tendon is reattached to the bone. So this is a rotator cuff repair. They come in different flavors. It depends when you get in there, how many anchors, where you place them. Is it one tendon, two tendons? But this is an example of a kind of the most common type. Again, the most common one is this tendon, the supraspinatus tendon, and this is the most common way we kind of fix it. So that tendon's reattached to the bone. Um, it's a tough recovery if anyone knows anyone that's been through it. Hopefully none of you have or none of you will need to. I suspect some people are here maybe because they need it or they're afraid they might need it. But, it's 6 weeks in a sling. It's not fun. Sling can come off for a shower, sling can come off to get changed. But for the most part, you're wearing that sling for 6 weeks. It's a lot of therapy, 3 to 4 months of therapy twice a week. And full recovery can be almost 6 months. The actual surgery is not that bad. Arthroscopically, like I said, we do these arthroscopic now. It's the same day. You go home the same day. Surgery takes about an hour. But that recovery is not fun but ultimately people do well. Tendon heals, tendon reattaches to the bone, and then you're doing well. This is just an example. I guess I was putting this in here to show kind of the evolution of where we're going. These anchors used to be metal, then they're plastic. Actually, a lot of what we use now, I did 3 rotator cuff tendon repairs today. We use these. They're actually not even a hard plastic. Those anchors that are going in the bone are a kind of a wad, that suture material, that shoelace type material. We put it into the bone, and then it kind of bunches up and gets trapped underneath the bone. So you're not even putting in plastic anchor. So maybe a little bit less pain, smaller drill holes in the bone, so less pain. The other kind of state of the art or kind of newer thing here that we're exploring is using patches to help these heal. That's the example on the left, doing the repair, but then adding a patch of cadaver, or sometimes this is actually animal tissue. There's one that's made out of porcine tissue, or another possibility or another role for these kind of patches is the tendon actually cannot be repaired. In some cases, people leave it too long. The tendon is too far gone, it's too torn, it's too retracted. There's something called atrophy. We cannot repair the tendon. We do have some options in some cases to use these kind of patches and try to make something work in those cases. All right, switching gears now. So we were talking a lot about the rotator cuff, and we'll kind of switch gears here now and start talking about shoulder arthritis, and how we approach that. In general, arthritis can affect any joint. And what is arthritis? It's the kind of wear and tear or breakdown of that smooth cartilage. If you remember back those early slides, I showed that smooth cartilage on the socket, and then you have a smooth cartilage on the ball side. When that cartilage starts to break down, that's arthritis. Eventually, the end stage of that is, bone on bone arthritis, when all the cartilage is worn and now it's bone rubbing on bone. What I'm describing is osteoarthritis. It's the most common form of arthritis. There's a little bit of genetics, a little bit of age, a little bit of wear and tear. There are other types of arthritis. Rheumatoid arthritis is an autoimmune disease where the body attacks that cartilage and breaks it down. Post-traumatic arthritis would mean someone, for example, broke their shoulder, damaged that cartilage, and kind of set in motion this breakdown of the cartilage. There's a couple other less common forms. Most commonly, this is osteoarthritis, and it's affecting the smooth cartilage on the ball and socket of that shoulder joint. You can have arthritis. I mentioned there's a couple other little joints in the shoulder area, that collarbone joint. You can have arthritis of the collarbone joint. It's actually very common, but it's not common for that to bother people. A lot of people get a little arthritis, get a little bump around their collarbone joint. It's very uncommon for that to actually cause a lot of pain because we don't have a lot of motion at that joint. The main joint in the shoulder area is that glenohumeral, that big ball and socket joint. It's way less common than hip and knee arthritis. Hip and knee arthritis, hip and knee replacement is very, very common. Shoulder arthritis is way less common, probably because we don't walk on our arms. So our shoulders are not usually a weight-bearing joint unless we're doing what this gentleman is doing. And so, because we're not bearing weight through that shoulder, it's often less or better tolerated than hip and knee arthritis and less common. The picture on the left is that normal ball and socket joint. On the right, you're showing this is a little kind of example of the arthritis. You see that cartilage is inflamed and broken and worn down. This is an X-ray example. So this is something you can see on X-ray. The other examples I gave, I talked about needing an MRI to diagnose it because it doesn't affect the bone. So you need the MRI to see those rotator cuff tendons. Arthritis you can see in the office on an X-ray. You start to see the ball is not a nice, perfect round ball anymore. It starts to become flat. It starts to make bone spurs. And then most importantly, you start to see this space here. If you can see my little arrow, the space between the ball and the socket has disappeared. Here you see a nice space that's filled with cartilage. The cartilage doesn't show up on the X-ray. So when that cartilage breaks down and wears away, you see the ball rubbing on the socket. You see that space gone. This example, we also see the ball has come up and it's starting to rub on the bottom of the collarbone or the shoulder blade. In terms of, again, where people feel it, it is the same. Almost all these shoulder things, it's very hard to tell. They almost all trigger this pain up and down here. So it's very hard to know based on where the pain is. Is it arthritis? Is it a rotator cuff problem? Is it a bursitis tendonitis? Although commonly the arthritis presents more with the stiffness. Yes, maybe the torn tendon. It hurts to lift, but the person can lift it, or in the office, I can lift it, I can move it because my tendons aren't torn. Versus arthritis will actually give you a stiffness. The shoulder becomes stuck, and you can feel that. You may feel some grinding, some clicking, some popping. We go through that whole treatment ladder, as always. Try not to rush to surgery. This is another one like the bursitis tendonitis. Give it a lot of time. Surgery is not an emergency. Physical therapy, anti-inflammatories by mouth. We can do injections, cortisone injections. But of course, there are surgery options. Let me go back. The injections. Yeah, some people ask, Again, because hip and knee arthritis is very common, especially knee arthritis, and a lot of people know about the gel injections, but a lot of people have had gel injections in their knees. Unfortunately, the gel injections, hyaluronic acid gel injections, are not FDA approved for the shoulder. And so Medicare and most insurance companies do not reimburse for hyaluronic acid, aka gel injections in the shoulder. So typically, if you're looking at an injection, you're talking about a cortisone injection. When it comes to surgery, broadly speaking, you're talking about some type of shoulder replacement, total shoulder replacement. Total meaning you're doing the ball side and the socket side. You have to do both because even if the arthritis is affecting more one side versus the other, if you put a metal ball and it's rubbing on a cartilage or rubbing on bone socket, it's not going to be good. It's going to wear away that bone and vice versa. So you're talking about a total shoulder replacement. There are two types. There is what you could call a regular or an anatomic shoulder replacement. It makes sense. It's the example on the left. You put a socket where the socket was, usually a plastic socket. You put a ball where the ball was, and that kind of makes sense. The ball does usually sit on a little stem that goes down, sits inside the arm bone. But then there's a ball where the ball was, there's a socket where the socket was. Then there's the reverse shoulder replacement. It's called a reverse because you're putting a ball where the socket was, and you're putting this cup or socket on the side that had the ball. So you're reversing it, which sounds crazy for lack of for lack of a better word. Suffice it to say, there are good reasons for this. I think I have a couple slides about it. The actual majority of the shoulder replacements we do nowadays are actually the reverse shoulder replacements. Probably about 70% of the shoulder replacements I do are reverse shoulder replacements because a lot of people meet the criteria or meet the indications to have a reverse shoulder replacement, and they will do better getting the reverse compared to getting the anatomic. This is a quick video. Let's skip through some of these steps. So yeah, the top of the arm bone does get removed. That's the arm bone. That metal stem goes into the top of the arm bone. Now this is jumping back to the socket side. The socket side is being prepared. We drill these little holes, clean up the bone, drill little holes for pegs, and that is the plastic socket going onto the socket side, usually held in place with a little bit of special bone cement. We're coming back to the arm side. That's the final stem going into the arm bone. And then you get a metal ball, and that is the new shoulder joint. The reverse shoulder replacement looks a little different. Come into the shoulder. And this is, we call this the base plate. So this gets screwed onto the socket side. Then you get this metal hemisphere called the glenosphere. It goes on that socket side. Metal stem into the top of the arm bone. This plastic cup that articulates with that ball. And this is the reverse shoulder replacement. A lot of these shoulder replacements, either way, whether you have an anatomic, aka irregular or reverse, from the patient's perspective, everything is the same. It's the same incision. They both take about hour and a half to be performed. Both of them can be done same day, go home the same day. Either way, you're wearing a sling for 4 weeks, 3 to 4 months of therapy, and about 6 months for full recovery. Thought I have a slide, but maybe not. So when do you get a reverse and when do you get an anatomic? Broadly speaking, the reverse is if the rotator cuff is not healthy. So if you have bad arthritis, bone-on-bone arthritis, and you need a shoulder replacement, and we've decided you need a shoulder replacement, the next step is to find out, yes, you have arthritis. What is the status of your rotator cuff? Many people that have arthritis, with time, the rotator cuff becomes very unhealthy or starts to tear or is partially torn. If on top of having the arthritis, the rotator cuff is unhealthy, we do the reverse shoulder replacement. And it's giving people better function, better ability to lift the arm, get rid of their pain. There's a couple other reasons. We will also do a reverse shoulder replacement in cases of very, very bad rotator cuff tears that cannot be fixed, especially in patients that are a little older, over 70, 75, and it's a big, big rotator cuff tear. And we're sitting in the office and we have a discussion about the chance of that healing. Sometimes they don't heal. Sometimes big, big rotator cuff tears do not do well if you try to fix them. We do have this option. We can do a reverse shoulder replacement in those cases. And then lastly, a couple other, I mean, sometimes a bad fracture, someone breaks the top, breaks the shoulder, breaks the top of the arm bone very badly. Um, in some cases, we do a reverse shoulder replacement if they do end up needing surgery. What is state of the art for shoulder replacement? One thing is going from these, the examples I showed all showed a traditional shoulder replacement, which is based off of a stem. So the stem goes down the arm bone. It goes down the canal, it goes down the bone marrow canal of the arm bone, and then the ball sits on that stem. Many times we can now actually do a stemless shoulder replacement. This is an example on the right of a stemless shoulder replacement. It's just got a small kind of supporting flange. So you're not kind of putting anything as far into the bone or disturbing the bone as much. This has to change. The slide has to change. There are now robots for shoulder replacement. Robotic hip and knee replacement came out a couple years ago. Valley was at the forefront of this. Valley has the Mako robot, which is Stryker's version of the robot for hip and knee replacement. Up until a month ago, I would have said there is nowhere that has robotic shoulder replacement. It is coming out now. We will probably have it at Valley in the next few months, end of this year or early next year. That Stryker Mako robot will be, we will hopefully be able to use it for shoulder replacement. So that is coming very soon, very exciting. Another thing, and this is live, I've been doing this for a year. Everyone that gets a shoulder replacement gets a CAT scan. It makes a custom. We have software. I can sit on my computer before every surgery. We load that CAT scan into the software. It makes a 3D model of the shoulder. The model can be manipulated in the software. You can plan the surgery. You can do the surgery. You can see if custom parts are needed. If it's a complicated, this is an example on the right showing a custom 3D printed guide. So the companies will 3D print a model of that shoulder that you're going to operate on so that you can have that in the operating room. It's sterile. And they'll also 3D print specialized guides that help you get the parts, those implanted parts, in the exact place you planned or you wanted to put them based on your 3D model. This is live. I've been doing that for years. I think that is it. That's kind of, we went through those three main topics. It's 7:38. I think that is
Okay.
good. And we'll open it up for some questions, maybe.
Thank you so much. That was so fascinating,
I,
interesting. So just a couple of questions. One is it better to repair rotator cuff tendon before it fully tears? I think you kind of alluded to that, but
I would say it depends on the size of the tear. I mean, if we have the MRI and it's 90% torn, and the pain is there, it's painful, and you've given it a bit of time. Yeah, that 90% tear is probably not going to heal. And the opposite is true. 10% torn. No, I would not say a 10% tear. Oh, well, you should just repair it because it's going to get worse. Not necessarily. We know that a lot of people can avoid surgery. So I would say that's completely depend on how bad the partial tear is.
okay. Are there exercises or stretches you would recommend for someone who has chronic neck and shoulder tightness to help with range of mobility?
Yeah, I think any type of, I mean, low impact stretching, like a low impact yoga or Pilates type of program, I think is great. It's a little beyond my scope to go through specific stretches. I don't think you want me up here. But you could certainly, I mean, I would recommend it. If the question is, would I recommend a
Hmm.
stretching program, a low impact exercise for someone with chronic neck and shoulder? Certainly, it's a great idea. Low impact.
Okay. Um, can you speak a little bit about the difference between delamination and tear?
Yes,
Should I
yes,
say that
yes.
right? Yeah.
Yeah. And I think
Delamination.
there was one, if I can back up,
Yeah, go
Susan, I
ahead.
think there was
Do you
what
see any of the
that first tear. Yeah,
yeah.
there was a quick one in the beginning. Partial thickness tear,
Oh,
same
yeah.
thing as partial tear. Yes. Partial thickness is the same thing as a partial tear. So can you speak a little bit about the difference between delamination and a tear?
Yes.
Yeah, delamination is a type of tear. So delamination, I would say, is a type of partial tear. So if we go back to that rope example where the tendons, rotator cuff tendon, all tendons are really made up of a lot of small collagen fibers. Collagen is a protein in our body. Our hair is collagen. Lots of our skin is made up of a type of collagen. So tendons are made up of collagen, millions and millions of tiny microscopic collagen fibers, and they're woven together to make the tendon. Delamination is when those separate a little bit, commonly in like a layered form. So you may see this delamination kind of refers to when there's a partial tear and it's almost like the tendon is separated into two layers and maybe there's a little gap. So instead of tearing off the bone, maybe the tendon has separated, it's developed a lot of some inflammation or fluid, and it's become a kind of two or three layers instead of a single layer.
Okay.
You have a full tear. Oh, sorry.
Hmm.
You want to
That's
read?
okay. You're seeing them there.
I've seen that. Yeah.
Yeah.
If you have a full tear and PT has
Mhm.
eliminated
Mhm.
pain, can surgery be avoided? I think that's very age dependent. In all honesty, with all respect. I don't know. No one's age is just here. If someone is a little bit older and they have a full tear, but PT has eliminated their pain, I would urge that person to live with it. Surgery can be avoided. I think they're fine. I think that's in contrast to a 30, 40, 50-year-old. If that person has a full tear, even if PT has gotten rid of their pain, I think that is pain is almost certainly going to come back. It's probably temporary. It's almost certain that at some point in their life they're going to flare it up again, and it might be better just to do surgery at
Mhm.
some point.
Right.
Acupuncture and chiropractic help. Yeah, I think acupuncture definitely for neck and back pain and chiropractic. I think I've seen a lot of people with good results trying these things. I'm all for trying everything
Hmm.
in those cases of bursitis, tendonitis. Try the acupuncture, try the chiropractor. I've seen it work. I've seen people get better.
Right.
Our tear is always painful, regardless of position of the shoulder.
So I.
No,
Mhm.
is that saying at rest? Tears, sometimes there can be a low level ache. Usually with the tear, you'll see though, when you lift, you get this sharp pain. So I think that person is asking like if you have pain
Mhm.
at rest, it could still be a tear. Tears can still give you pain um, at rest. What?
Well,
Ooh, a lot of questions.
I know. I know. I'm having you screen them, doctor.
Oh no, I'll just try to get through them quick.
Sure.
If what type of
Hmm.
tear injury could result from a fall where you land totally on the shoulder? Um, anything could happen. Fall where you land, you could break a bone, break the collarbone, break the top of the arm, tear one tendon, two tendons. Just could just be a contusion. It doesn't even have to be a tear. If you know that you have bone-on-bone arthritis, is surgery absolutely the end result? No, no. A lot of people live with it. Pain is a fascinating subject. I can do a talk just on pain. A lot of a lot of pain is mental. Some people are fine living with it. They find ways to adapt. They find ways to live with it, and um, you never have to have joint replacement.
Hmm.
Can a small tear in the rotator cuff heal on its own? Yes. If it's rested, yes. Is it okay to exercise with weights if you have osteoarthritis, do planks, etc., to keep the rest of your arm in shape? Yeah, yeah. Low again. If you have known arthritis of any joint, for sure, it's okay to exercise, to do light weights, high reps, high rep kind of low weights, and that's fine. You just have to learn. You have to learn. You're gonna find what flares it up, what doesn't. Osteoarthritis can have flare-ups. You can have a good day, good week, bad week. You have to learn what are your limits, what you can do in the gym so that you can live with it.
Right.
Can tears happen without physical trauma to the shoulder? Yeah. At some point there is trauma, there's micro trauma, but if the question is can tears happen without major trauma, for sure. Though there are those, I think I gave the example, those wear and tear, slowly fraying type of tears that can just sneak up on you. I received both gel and plasma injections, neither of which was successful. Are there any other injections you could recommend? Cortisone.
Mm-hmm.
People have some concerns about cortisone. We do them all the time. It's pretty reliable. It does help, and it's a lot cheaper than those
Mm-hmm.
injections. How much pain do you have with shoulder replacement after surgery? That goes back to
Mm-hmm.
my pain, my comment about pain.
Right.
Pain is very variable. I have patients that tell me they never need. We give people oxycodone as we do give, almost everyone gets a prescription for oxycodone. We do a multimodal pain approach. We give everyone a lot of Tylenol. We give you an anti-inflammatory. This company will rent you an ice machine if you want it. We do give you the oxycodone if you need it. We give you a prescription. I have patients that tell me they never needed it.
Mm-hmm.
So pain is variable. It's hard to know. What could be a pain in the middle of the arm? Yeah, that upper arm pain, that pain here, that can be almost anything. Almost anything. If it's turning on those pain fibers in the shoulder, it'll trigger that pain in that upper arm. It's pretty vague. Oh, that's just a thank you. You're welcome. So are you saying at age 65 and older would be best to avoid surgery if PT eliminated pain? 65, I assume they're talking about a rotator cuff tear. Either way, if they're talking about rotator cuff tear or arthritis, age 65, PT eliminated the pain. I would ask you if you're doing everything you want to do. If PT eliminated the pain and you're back to doing everything you like to do in your life, whatever that is, golf, tennis, pickleball, kayaking, fishing, if your PT eliminated the pain and you're back to doing all that stuff, avoid surgery, sure. Is the prognosis affected by age and number of prior surgeries? I've had repeated rotator cuff repairs, very advanced reverse shoulder replacement has been recommended. No, you're a good candidate for reverse shoulder replacement. You're the that's what it's designed for. Someone that's had the rotator cuff surgery and it failed, it didn't work, or they just can't have the rotator cuff repair. You're a good candidate. Hello, doctor. If I need to repair my bicep tendon, what will there be the recovery? When will I be able to drive 61? 3-4 weeks in a sling, 3-4 weeks no driving, broadly speaking, but case dependent.
Mm.
If you hear or feel, oh, they keep coming, Sue.
I know. You cut it off at one point.
No, I mean,
If you hear or feel scrunchy sounds,
yes. You hear or feel scrunchy sounds, is that a bad sign? If it hurts, if there's a pain associated with them, no, lots of joints click and pop and make noises. And if you're not having pain, ignore it. But if every time if that pop comes with a pain, yes, usually something wrong with the tendon, but not very specific. I had MRI 4 years ago, showed torn labrum on one side. X-ray last year showed large bone spurs. X-ray last week showed no gap in the joint. I'm 67, already have hip replacement, so sounds like a candidate for total replacements. Yes. Yes, sounds like shoulder replacement. 74 due to OA, I need a shoulder replacement. What are the risks? I mean, we go through everything. Anything is possible. The most common risks are some stiffness. A lot of people may not get full all the way up, but they're still happy, no pain. Some people still have some pain. The big risks, the scary things, parts can come loose, parts wear out, needs to be redone, infection. Those are kind of the main risks we talk about. Downside to repeated cortisone injections. Depends on age and current status of the joint. If you have a lot of arthritis in the joint, I don't think it's so bad to have some cortisone injections as long as they're spaced out appropriately, as long as they're spaced 3 to 4 months apart. Platelet-rich plasma an option. The scientific studies are all over the place. That's why insurance doesn't cover it. Platelet-rich plasma is a form of, kind of people lump it in with stem cells, kind of stem cell light. Platelet-rich plasma. I don't push it because it's definitely, no one's ever shown this a permanent solution that you're going to get a platelet-rich plasma injection and you can 100% cure your arthritis. Maybe for some tendon problems, small partial tear. If anything, I would say platelet-rich plasma for a small partial tear,
Mm.
but insurance doesn't cover it, unfortunately. If resting a small rotator cuff tear, does the tendon reconnect itself to the bone? Yeah, if it's a partial tear, if it's a small partial, if by small you mean a partial tear, the tendon can heal. Oh, here's a very specific one. I saw you 2 years ago for my left shoulder. You said it was bone on bone. You recommended surgery. I was a recent heart valve replacement and pacemaker recipient, but then the question cuts off.
Hmm.
So I did. Hmm.
And
Wonder.
gel injections effective despite not being approved. Hmm.
They probably do help. Yeah,
Mm-hmm.
I've had people willing to pay out of pocket. Again, not a miracle though. That's why I don't push
Mm-hmm.
them. I don't like pushing them because not a miracle.
Okay.
Testimonial. Deep cortisone as recommended acid is exponentially more effective than standard injection. Yeah, you have to get it in the right spot. Yeah, usually we do ultrasound guided to make sure it's the cortisone's in the joint space. If taking anti-inflammatory, is that indicative of arthritis or could it mean? No, it could mean anything. Tears will be inflamed. Arthritis is mediated by inflammation. Are you taking new patients? Yes. Thank you. Does the body ever regenerate a full tear? No.
Hmm.
Full tears don't. Did cortisone a few times. Now my right shoulder is starting up. I'm afraid of surgery. I'm 80. Is there arthroscopic surgery? No.
Hmm.
No.
Oh boy, thank you so much for answering every single question. Thank you so much, Dr. Dasti. That was so comprehensive, so interesting, lot to think about.
You're
Um,
welcome.
so at this time, I'd like to remind everyone home to take a few minutes to fill out the survey using the link that we will be emailed to you shortly at the completion of this presentation. So just look for that and let us know what you thought if you can. If you are interested in future Valley live events, please visit www.valleyhealth.com/events for upcoming programs. This program and others you can view or hear again by going to www.valleyhealth.com/tune into health. That's one word. www.valleyhealth.com/tune into health. We should have this up in a few days. So thanks again, Dr. Dasti. Everyone have a wonderful evening and we'll see you again soon.